Yeah, started. Okay.
Good evening, everyone. Welcome you all for this third session in the hematology course. And today's topic is hemolytic anemia, another very important topic for general practitioner, not from the point of treatment, but definitely from the point of when to suspect, how much to evaluate, and referring appropriately. And also, when they're coming to us for follow up, how comprehensively to look at them and what are the counseling points. These are very important for us as a general practitioners. And for this topic, we have with us Dr. Nishit. He has done his internal medicine and a fellowship course in clinical hematology. And he has a vast experience in hematology, over 7 years experience, and has done over 145 BMT and has treated more than 1,800 patients. So I welcome Dr. Nishit and over to you, sir.
Good afternoon, everybody. Can you hear me? Is my voice
Yes,
quality clear?
yes, yes,
So
sir.
today we
Yes, sir. Yes, sir. Yes, sir.
yeah. So today we have a topic called hemolytic anemia: when to suspect and how to evaluate, and briefly covering the treatment aspect, but very briefly. So what is hemolytic anemia? So hemolytic anemia is premature destruction of red blood cells. That is two ways. One is antibodies directed towards the RBC antigen, and the non-immune way where there's the destruction of RBC membrane. So the first thing when we look at a hemolysis,
Audience.
we want to differentiate into two criterias, whether it is immune type meaning whether it is direct Coombs positive, indirect Coombs positive, or a non-immune type. Once we have established whether it is immune type or non-immune type, if it goes towards non-immune type, then we look at where the destruction is happening, whether it is happening extracorpuscle, that is away from the structure of the cell. Extracorpuscle is also similar to intravascular, and intracorpuscle is similar to extravascular. Okay, so extracorpuscle, as you know, corpuscle means cell, so away from the cell. Intracorpuscle means any defect in the cell. So again, when you're looking at extracorpuscle, we have a diagnosis towards TMA, that is thrombotic myoangiopathy.
Dr. Nishit, sorry to disturb, but we are not able to see the slides. It's not changing.
Oh, is it? One second, I will stop sharing and reshare again. Okay. Thank you.
Yeah, sure.
Can you see now?
Yes, sir.
Yes, we can.
Yes,
Yes.
yes.
One second, there's some issue. Hello. Actually, there's some issue happening with when I'm sharing the slide, so it's not moving. So can somebody share the slide from there? And
Um,
Dr. Nishit, can you try doing it now? Because initially you did, it happened.
yeah, because initially I went out of stop sharing, so then it happened. Then happened for some time before again a lot of people joined and then it stopped.
Oh, okay. Uh, Hema, can you share those slides with me?
um,
I'll do a screen share, or if you only can do screen
uh,
share from there.
yeah. Sir, we don't have
Now
your
it's moving.
slide. Now it's moving. We don't
Yeah,
have your
one second.
slides actually.
Yeah, one second. Now can you see
Yeah.
it?
Yes, it's
Yeah,
moving.
yeah.
Yeah,
It's
now it's
moving.
moving.
Yeah, but the thing is not moving here. So it's okay. I can see it on the big screen. So, as I said about the hemolytic anemia, it will relate to the antibodies which are directed against RBC antigen or a non-immune breakdown of RBC membrane. So, first thing we have to do is we have to do a immune test. So, immune test is direct Coombs test or an indirect Coombs test, and then differentiate whether it is positive or negative. So, suppose it comes negative for non-immune, then non-immune is divided into two criteria, that is extracorpuscle and corpuscular means a cell. So whether the destruction is happening outside the cell, that is extracorpuscular can also be intravascular or intracorpuscular, which can be extravascular. Because if the destruction is happening within the cell. So few examples are in extracorpuscular is TMA, that is thrombotic microangiopathic anemia. Intracorpuscular, whether the defect is in hemoglobin, whether the defect is in membrane, or if the defect is in enzyme. So if you take RBC as the cell, the defect can either be in the hemoglobin attached to the cell, or the membrane of the hemoglobin, or the enzyme of the hemoglobin. So there are some terms which different people use, and sometimes they tend to overlap with each other. The etiology can differentiate from the time of presentation or the morphology or where the destruction is happening. Yeah, but in the beginning itself, where you have to establish whether it is immune related or non-immune related. So if you look at this example of hemolytic anemia, so this has taken it based on the inherited and acquired causes. In inherited causes, which are generally non-immune type, there's a membrane defect which has hereditary spherocytosis, elliptocytosis, enzyme defects like G6PD, pyroid kinase deficiency, and other hemoglobinopathies like sickle and THAL. Then coming to acquired causes. Now, in acquired causes, again, it is immune mediated and a non-immune mediated. So in immune mediated, it can be alloimmune, which occurs in hemolytic disease of the newborn, or hemolytic transfusion reaction. So for alloimmune, the antibodies which are presented by the patient should be against some other phenomena. So like if a lot of blood transfusion is being given, so those antibodies are making antibodies against the blood transfusion, or in pregnancy the mother's antibodies are crossing the fetus through the placenta and they are destroying. In autoimmune there are again two types, warm type and cold type, and paroxysmal cold hemoglobinuria is somewhere in between. So in autoimmune warm type, we have idiopathic, which we don't know, CLL, lymphoma drugs. In cold AIHA, most common is mycoplasma infection mononucleosis. Now, if once the immune part is taken care of, we can shift our diagnosis if the Coombs test has come negative to the non-immune type. In non-immune type, we have MAHA, microangiopathic hemolytic anemia, infection, renal disease, some drug, and hypersplenism. Now, this was the general overview of the etiology. Now, based on the type of etiology we are looking at, that will help us to take a proper history. Now, for example, if I'm looking at autoimmune, where the antibodies are against the self RBCs, as explained. So, my questions towards the patient would be that did the phenomena happen since birth, or has you developed it recently? Is the drop in hemoglobin was there from before? How many blood transfusions have you gotten? So we can rule out alloimmune. And then in alloimmune, as you can see, antibodies against somebody else RBC. That is through multiple transfusions. Now, if he says yes, the drop has been immediate, then we have to look for whether the cause is primary or secondary. So in primary, there's no underlying cause. It is idiopathic in nature. In secondary, we are dealing at lymphomas, various Waldenström macroglomia, where conditions where lymphoma is the baseline thing, but on that they present as autoimmune phenomena. Coming to the third aspect, where is the destruction happening? Whether the destruction is happening in intravascular. So as discussed earlier, intravascular means extracorpuscle. That means RBCs are destroyed in the circulation. Extravascular means intracorpuscle, the destruction is happening within the spleen. Now, after we have ruled out based on the history we've reached here, we have to also take important history, whether the thing was present to him from congenital. Matlab, right after birth, is the person having any problem on taking some medicine, some drugs, or any other transfusion? So we have to rule out congenital and other acquired causes. So this is the general briefing. Now coming to the next slide, we will look at the clinical presentation, how the hemolytic anemia patients usually present with. So they will give symptoms of tiredness, and we have to ask them since when, shortness of breath, the duration, dizziness. In history, the important points which we should document is immediate post-transfusion reaction. Has the patient required number of transfusions since birth? That gives a very important clue for thalassemia. The urine, they will tell that he takes one tablet and after that his hemoglobin drops and his urine becomes dark in color. That is giving us a very important clue for G6PD. The patient will look more yellow in nature, so again giving us a thing of jaundice. Whether the symptoms were exacerbated by cold, so in cold autoimmune, those history will help us. In medication history like anti-malaria, antipsychotic medicines, they will help us. At birth, what was the presentation? In gallstones, this is a very important history. Some patients will tell the patient had repeated jaundice, gallstones, and you will be trying to look at hereditary spherocytosis. A strong family history, because thalassemia, sickle, they are all autosomal recessive, while G6PD is X-linked recessive. So more often or not, it will be running in family. Acute chest syndrome is for dyspnea, acute exacerbation. This helps us to find the diagnosis with along with joint pains if we are looking at sickle cell. So these are some of the important history which we ask all the patients, which will help us to quickly put a diagnosis towards one of the causes of. So immediately we'll order a Coombs test, or called as DAT test, direct anti-globulin test, in which if it comes positive, we are looking at autoimmune, alloimmune, or drug-induced hemolytic anemia. If the DAT comes negative, then we are looking at the structural defects like hemoglobinopathy, membranopathies, or any thrombotic microangiopathies like TTP, infections, or any enzyme defect like G6PD. So what is this Coombs test? So if you can look at the slide, in direct Coombs test or direct antiglobulin test, we take the blood sample of the patient and which is already been coated with immunoglobulins, and we directly add antisera to it. And if once the antisera is added to it, that antisera will attack the immunoglobulins which are already present on the RBC surface, and they will come together and agglutination will happen, leading to destruction. What is indirect Coombs test or indirect antiglobulin test? In this, the recipient's serum is taken and containing the antibodies, and it is mixed against the donor. So recipient serum is taken where the antibodies are. It is mixed against the donor blood, and once the donor blood is mixed, the recipient antibodies, that antisera will go and strike on the surface. Then again, like direct Coombs test, anti-human immunoglobulins are given, and the results will show agglutination. So the basic difference is in direct Coombs test, directly anti-sera will show a reaction, while in indirect Coombs test, the plasma is taken and RBC of the donor is mixed together. First, that reaction will take place, and then when anti-sera is added, then the reaction will show place. So not all direct Coombs test and indirect Coombs test can be weakly positive in normal human beings also. So we should look in a score of 4, the 3 plus and above, which are considered significant in nature. So as we discussed earlier, the DAT positive and DAT negative are the first breakthrough point in hemolytic anemia, which helps us to differentiate whether immune cause from a non-immune cause, because the treatment is completely different. Identifying the red cells coated with antibodies or complement, the principle I just explained, using anti-human antibodies to detect immunoglobulins or complement found in vivo to RBC membrane, leading to agglutination and a positive result. So the two types of DAT positive can be there, whether it is warm type or a cold type. In warm type, the antibody binds to red cell. Optimal temperature is 37 degree. In cold type, the red cells require colder temperature as low as 4 degrees Celsius. So one common problem which you will face in the cold type is one history you can get by your lab technician that he is not able to make a smear at all. As he is taking out the sample, the blood is clotting immediately. That gives a very important clue. So again, indirect Coombs test, I have already discussed the principle and how indirect Coombs cells compatibility test is for antibody identification, RBC phenotype, and titration studies needs to be done. So indirect Coombs test comes significant when a patient is receiving multiple transfusions or we are dealing with hemolytic disease of the newborn. So this is the two picture in my microscopy. Can anybody tell me what is the arrow pointing in A and what is the arrow trying to point in B?
Every 6 to 8 weeks and spherocyte in A.
Yes.
And B, there are fragments. The final subheading on mental health, how will you? It's fragment or pregnancy, antipsychotic, and
so as somebody rightly pointed out, A is for spherocytes. Actually, spherocytes, as you can see, the RBCs have lost the central pallor, but this is not a good picture because I should have compared it to the nucleus of a small lymphocyte. So a lymphocyte should be ideally be in the same picture, and then the nucleus size is compared to that. Second is B. B is nothing but cystocytes or fragmented cells, which are seen in MAHA, that is microangiopathic hemolytic anemia. So a counting of cystocytes more than 1% is considered significant. So primary, secondary, and secondary examples for the conditions in warm autoimmune hemolytic anemia versus cold versus mixed. The diagnosis is based on mostly IgG in warm types and IgM in cold types, or C3 known as CHAT, that is antibiotic. So once the warm type is there, again the diagnosis towards secondary causes are very, very, very important. We should not start treatment for any autoimmune hemolytic anemia without thoroughly evaluating a patient for secondary causes, because you will end up treating the autoimmune hemolytic anemia, but you might miss the underlying cause, which could be a lymphoma, because you know most of the autoimmune requires steroids. So once lymphoma is masked, you might feel the patient is showing benefit, but actually the lymphoma is underlying it, and then the patient will feel discomforted because you have missed the diagnosis in the beginning, and now the lymph nodes are very small and they cannot be biopsied and a proper diagnosis can be given. So before starting any treatment for autoimmune hemolytic anemia, first we have to rule out what is the underlying cause, and mostly lymphomas have to be ruled out. So other investigation, as we know, reticulocyte, which is also known, gives us a bone marrow responding status, is raised. Marrow shows response to anemia leading to macrocytosis. LDH is also raised. Unconjugated bilirubin is also raised. Increased hemoglobin breakdown it indicates. Haptoglobin is decreased because it binds to free hemoglobin and comes out through urine or fetus. That shows us the color of urine being dark in nature. In that, positive immune cases of hemolytic anemia, blood film may show abnormal RBC, detects immunoglobulin or complement bound in vivo RBC. Morphology depends on the cause of hemolysis. So urinary analysis of hemoglobin urea was earlier done very rapidly, but I think some of you might be in periphery centers where you can still do a positive urine deep stick thing, but microscopy can be still negative for RBC. Meaning, if you look through the microscopy, you are still getting negative for RBC, but because the RBCs are getting destroyed, you can still pick up the hemoglobin urea. Occurs in acute intravascular hemolytic anemia that exhausts the haptoglobin binding capacity and gets filtered through the glomerule. This is another chart which helps us to see if the DAT is come IgG positive or and C3 negative, or both are positive, or C3 is only positive. So that helps us to differentiate between the warm type and the cold type, which I've already discussed earlier. Main thing for any autoimmune secondary causes, lymphoma has to be ruled out, Waldenström macroglobulinemia has to be ruled out, any underlying infections, especially viral infections, have to be ruled out, and a detailed drug history has to be taken. So some causative drugs that cause autoimmune hemolytic anemia, beta-lactam antibodies like penicillin, ceftriaxone, and NSAIDs like diclofenac are anti-malarial, which we have already spoken.
Uh, Sir, you're not audible.
You're muted.
Again, the slide has stopped shifting actually. So that's why we were trying to fix that issue. Again, give us 2 seconds, please. Again, the slide is not shifting, is it?
It changed to next slide. It's not changing, sir.
Changing from now, it's not changing. Changing here, not changing. Change that.
Yeah, it's moving, sir.
Yeah, okay, got it. So as we discussed the drug, sorry for the delay. So there are some special appearances which we can see in a microscope, based on which we also can give a hint whether it is autoimmune type or any acquired causes are present. So some special sizes or shapes of the cells can be picked up. So these are called poikilocytosis. If you see a spirocyte, that is complete spherocyte, because in the edge of the microscope, we'll always get spherocytes. So one thing is very important, that we should not go to the edge of the microscope. We should only see a part when the RBCs are just touching each other. And for a pure spherocyte, it has to be always compared to the nucleus of the small lymphocytes. Because if you see any peripheral smear, if you go to the edge of the smears, there are a lot of spherocytes present. If any blood transfusion has been given, you will see a lot of spherocytes. So that history has to be taken. So in inherited causes, if you see spherocyte, we are dealing with hereditary spherocytosis. In acquired causes, if you see, we are dealing with autoimmune hemolytic anemia. If you see cystocytes, as we discussed, even more than 1% is significant. We are dealing with MAHA, that is microangiopathic hemolytic anemia. For a bite and a blister cell, we are seeing due to G6PD deficiency. So the G6PD and pyruvate kinase deficiency, they are non-spherocytic in nature. So they come under this criteria called hereditary non-spherocytic hemolytic anemia. The main feature is the premature destruction of blood cells where the RBCs are not sphere shaped and it is in an inherited condition, genetically inherited disorders. You will see jaundice and on examination, you will find hepatosplenomegaly. Now, brief treatment for all the condition. Most of the patients will require supportive care and according to the cause. Now, suppose you have a patient with hemoglobin of 5 and you are certain that this could be an autoimmune hemolytic anemia. So for a hemoglobin of 5, we should only give 1 unit of PRBC and try to maintain the hemoglobin around 7. If you try to give excess PRBC and try to get a hemoglobin of 10, there is a chance that the patient can have a faster hemolysis and the patient can deteriorate. So for supportive care and according to cause, inherited DAT negative hemolytic anemia, as we discussed, can sometimes present with gallstones. G6PD can avoid precipitating hemolytic anemia. So for G6PD, it is very important to take a history from childhood because it is very transient in nature. It does not be present all the time. So the history will be on and off, on and off. And the patients of G6PD, if diagnosed correctly, they are very well aware of the medicines that they should avoid. So they will come to the hospital or the physician and they will tell, look, I've already have G6PD and these are the medicines the doctor had told me to stop taking. For sickle cell anemia, luckily for the Indian population of sickle cell, most of the patients, they do not require bone marrow transplant. But for the African population of sickle cell, the sickle cell anemia is very severe and the only treatment is bone marrow transplant, which is the definitive treatment. But in terms of supportive treatment, we have to maintain the hemoglobin between 9 and 10 by giving hydroxyurea, supportive care. If they come with drop in saturation, we have to give oxygen supplement. We have to give hydration because there are features where sickle cell crisis can occur, whether it can occur due to dehydration or any underlying infection in which sickle cell crisis can precipitate. For thalassemia, for minor, only folic acid is required. For major, we have to give transfusions. We have to do iron chelation properly. And of course, bone marrow transplant is the only definitive treatment for transfusion-dependent thalassemia major patients. Now, once you have diagnosed AIHA and you have ruled out all the underlying causes, then you can start with corticosteroid in case of IgG positive, DAT positive AIHA, which is warm type. If the steroid fails, you can go to rituximab, which is the second line of therapy. If that also fails, then really splenectomy is required. In cold AIHA, avoid exposure to weather and keep the body warm. Then in case of MAHA such as TTP, it is a medical emergency. The patient will come in ICU with low platelets, high creat or borderline high creat, low hemoglobin, and the peripheral blood will be showing cystocytes. And immediately, even before waiting for Adams 13 assay to be done and the report to be released, there's a plasmin score which you can calculate. And if the plasmin score is between high risk and intermediate risk, you immediately start for plasma exchange because that initiation of plasma exchange can save the patient's life and make a huge improvement to patient life. Currently, we have at least 6 patients whom we started plasma exchange, even waiting for the Adams 13 assay to come, and they are all doing because there's a drastic improvement if they have started on rightly. And then, of course, corticosteroids can be given. For DIC, as we know, the underlying cause, whether it is infection or APML or the leukemias which can present, that needs to be corrected as well. So what are the complications of hemolysis? We can have a risk of venous thromboembolism, pigmented gallstone secondary to chronic hemolysis, and high output cardiac failure. Some of the key points which I discussed today was hemolytic anemia, whether it is intravascular type or extravascular type based on destruction, based on immune type, whether it is DAT positive or DAT negative, and whether reticulocytosis, increased LDH, which is seen in all of them, increased unconjugated bilirubin levels, decreased haptoglobin levels, confirms hemolysis. Early support care in hemolytic anemia is important, may involve transfusion and folate replacement. This is a nice flow chart in which we can see different shape and sizes of the cell, and based on that, we can come to a conclusions in stepwise manner. So after this topic, I have 3 patient discussions with you. If you're okay, I'll proceed to the next one. Till now, any questions if somebody wants to ask, I'm happy to.
Any questions till now?
Sir, I have one small
We-
question.
Yeah, please go ahead.
Looking at the CBC and
Yes,
peripheral smear.
yes,
Peripheral smear, generally it's morphology of the RBCs they reported as normal, normocytic, normochromic.
yes,
So any points to say is this could be a patient of hemolysis?
yes.
Only
So
looking at the
you,
CBC and PS.
yes. So you will see lot of polychromatophils. That is like reticulocyte without doing a special stain for reticulocyte. You will see lot of polychromatophils. Or if you see a smear which is showing more than 20% of spherocytes, irrespective of whether you are seeing in the middle from the middle of the smear to the end of the sphere, a lot of spherocytes are there, or cystocytes are being seen, which are more than 1%. So these 3 significant findings will help you. In terms of bite cells and cleave cells, it is difficult to pick up unless you know already that you are looking at a situation. But in thalassemia, you will see targeted cells. So you will see a RBC, and in that RBC, there'll be a dot. And in sickle cell, there'll be a proper sickling of a cell that is also more than around 20%. So these are the some of the poikilocytosis which can help you to give some hint for which you will might ask for a extra history from the physician that sir, we are looking at these things. Are you suspecting any hemolytic anemia?
Okay. Thank you, sir.
Okay. Somebody has
Sir,
messaged 2
namaste,
questions,
sir.
I think. Yeah, please go ahead.
Sir, good evening, sir.
Yeah, good evening.
Sir, there is a 17 years old boy whose hemoglobin is 17 grams, sir. He is now
17
complaining
grams.
of 17 grams. Now he is
Okay.
complaining of sweating and little bit giddiness. How
Okay.
to approach him, sir?
Yeah, so when the hemoglobin is high, the
Amen.
cutoff first you should be thinking towards a condition called polycythemia. So
Yes, sir.
yes, so in polycythemia, the main thing you have to rule out is whether it is polycythemia vera or any secondary polycythemia. Okay, so
Okay.
for immediate improvement, since he's already complaining of a headache and sweats, so there are 3 history we usually ask for: any joint pains, any headache
Okay,
which you have
sir.
already asked, any blurring of
Okay.
vision, any aquatic pruritus. When he's
Okay,
taking a
sir.
bath, does he have itching? Look for
Okay, sir.
any hepatosplenomegaly. Look for
Okay,
any
sir.
congenital heart defect by 2D echo. Look for any
Okay, sir.
chest X-ray for COPD and others. And
Okay,
then
sir.
for confirmation, send a MPN panel that includes JAK2 mutation with exon 12, MPL,
Okay, sir.
CALRA, as well as BCR-ABL. These are the 4 genes that need to be evaluated immediately.
Okay, sir.
Okay. Then
Okay,
we
sir.
have to do a bone marrow aspiration biopsy in which pan-mylosis will be seen. That is, all the 3 lineages might be increased. This
Okay,
is the
sir.
complete evaluation for polycythemia. with you have taken a personal history of smoking and alcohol. And for treatment, you immediately start the patient on a venesection. That is removing
Okay.
blood 350 ml. That will give him symptomatic relief. Now you
Okay,
do
sir.
the venesection to maintain the HB less than 15.
Okay, sir.
Okay, and PCV less than 45. That is how you
Okay,
do
sir.
at venesection. Second is you start him on EcoSprint 75 mg. Now there are
Okay.
5 criteria which are called high risk criteria in which hydroxyurea needs to be started. If the patient has already had a stroke, okay,
Okay,
or
sir.
any thrombus anywhere, or if WBC is more than 10,000, if there is vasculitis for the patient, he's hypertensive or diabetic. In those conditions, hydroxyurea is started upfront, or age is more than 60. So these are upfront condition where hydroxyurea is immediately started. If not,
Oh,
then you hold back the hydroxyurea. Now, if
oh,
your JAK2 and mutations come positive, then you continue treating with venesection till HB comes less than 50. Now, however, if your sorry, there's one more test called erythropoietin which we have to send. Erythropoietin
sir.
will be low in case of polycythemia vera. Now, if
Yes,
you
sir.
think Vera is not the diagnosis, then the decision to do venesection only matters if the patient wants symptomatic relief. Because if
Yes,
doing
sir.
excesses of venesection also can lead to
Hmm.
problems later. Okay.
Okay.
So,
Okay, sir.
although it
Okay.
is a different topic from today, but
I
I
think we
hope I
have
have
a
addressed.
topic discussion on this. Maybe questions we can restrict to only hemolytic anemia.
Okay, madam.
We
Okay,
have
madam.
a separate discussion on this.
Okay. Thank you. Thank you. Thank you, sir. Thank you.
No,
Sir, good evening.
sure.
Just one doubt.
Yeah, please
Hello.
go ahead. Yeah, please
Yeah,
go ahead.
a 21-year-old last week I had a case. 24-year-old female, primary gravida only.
Yeah.
Hello.
Yeah, we
Hello.
can hear you.
Yeah,
Please.
yeah,
Yeah,
go
please
ahead.
go ahead. Please go ahead.
Yeah. Pre-op, all the investigations were normal. On second
Okay.
POD, suddenly she had creat 2.5 and she went into thrombocytopenia 50,000. And her
Okay.
hemoglobin on second day, it was 10.
Okay.
Then she was shifted to my center. Then we have observed her. It was looking like autoimmune hemolytic anemia. On second day, her hemoglobin went down to 6 and creat was increased. Again, thrombocytopenia was severe. It was
Okay.
20,000. It looks like whether any other diagnosis other than autoimmune hemolytic anemia. Like we don't know the
I would,
etiology. So we
in this case, sir, I would also look at a condition called HELP syndrome.
yes,
Okay.
sir. Liver enzyme LF was absolutely normal, sir.
Yes. Then if you have ruled out HELP syndrome, then we can look because of infection, underlying DIC could have occurred. So that can also cause hemolytic condition. So I would think towards a more like a microangiopathic hemolytic anemia after I have
Yes,
ruled out. Because
sir.
creat being involved, it's usually a diagnosis of HUS being elevated. So my first diagnosis would have been HUS through secondary to some torch infections, which are common in female of that thing. So this could be one of the diagnoses I would look into, as
Yes,
you
sir.
rightly.
After that ruling of na, I just transferred SDP and referred her to NIMS hospital to Hyderabad.
Okay.
Yes.
Okay. So there are 3 patient discussion I want to discuss with you all. So we'll go. Can I proceed further with the discussion? 3 patient.
Yes, sir. We'll go ahead with the cases. Then we
Yeah.
can take more questions.
Yeah, sure. So now there's patient number 1, which is a 28-year-old female, complains of generalized weakness, reduced appetite since 1 month, pallor is present, mild icterus is also present, mild splenomegaly. Investigation shows HB is 3, WBC also slightly on the lower side because neutrophils are less than 1,500, platelets are 10,000. If you look at the bilirubin in LFT, it is more towards indirect. Serum creat was normal. So any further investigation would you like to do? And what are the further investigations you would like to do? Anybody wants to take up?
Because of all cell lines are reduced, we have to go for level of
So
redemption. folate.
Yeah. So what would you like to ask? Sorry, could
Sir,
not
one
hear.
is the peripheral smear.
Peripheral, but
Yes,
for
very good.
Second one is
Okay,
vitamin B12 test.
very good. Hmm. Okay. Anything about autoimmune would you like to rule out right now? Okay, so further investigation, as somebody rightly pointed out, we did a direct Coombs test, which was negative. Indirect was also negative. Peripheral smear showed hypersegmented neutrophil. LDH was 2000. Vitamin B12 was 80 and folate was only 7.
Vitamin B12.
Yeah, so this is a
Vitamin
diagnosis of vitamin B12 deficiency. So not all the time
B12.
hemolysis would be due to autoimmune or any hemolytic anemia. We have to also keep a diagnosis of vitamin B12 in our mind. The difference would be that in vitamin B12 deficiency, mostly all the three lineages could be involved. So it would be more like a pancytopenia picture. And one important history we could have taken was if the patient is vegetarian or not. Okay. Now we'll move on to the next case.
Sir,
Patient number 2.
one doubt.
Yeah, please.
The direct comb test and indirect comb test we can ask together, sir. I bit of confusion I had.
No, you can
Direct comb
always,
test.
yeah, you can ask together.
Okay.
Sir,
See.
there is another. So I just wanted to ask you something.
Yeah, sure.
The B12 sometimes one of my patients, three different labs, I got three different values, and it was very difficult to even assess whether there was B12 deficiency or not at all. So how do we decide whether it is B12 deficiency in
Okay.
that kind of
Okay.
patient?
So what was the age of your patient?
Around 40,
Okay.
38,
So
40.
yeah, so one thing is that in young patients, usually if you start giving vitamin B12 corrections, the patients will usually respond within 7 days in terms of anemia and WBC and 14 days in terms of platelets. Okay, that is the response time to a vitamin B12 correction. Now, sometimes what happens is that the patient could also be telling some kind of gastritis with vitamin B12. So one thing important to rule out is pernicious anemia also at that time. So you have to ask for antiparietal antibodies, or if he has any other autoimmune thyroiditis. So you have to look at the complete ANA panel and rule out any antiparietal bodies which can be or any anti-intrinsic factor bodies, because then they will require multiple types of correction. So that can also happen. So one more thing, if you have given transfusion, please do not send for vitamin B12 because one packet of PRBC can correct vitamin B12 up to 6 months to a year easily. So your reports will always come high, irrespective if the patient is having vitamin B12 deficiency. Okay. And always try to correlate with your vitamin B12 with a LFT and a LDH. It will give you good guidance. In terms of young patients, if it was an elderly patient, usually if you have given multiple vitamin B12 correction, then please look at MDS myelodysplastic syndrome because presence of megaloblast itself could be a signs of dyserythropoiesis and we have to do genetics test to rule out whether the patient is suffering from myelodysplastic syndrome because that is the most common presentation a patient will come with that I have taken repeated vitamin B12 correction. However, yet my WBC is only this much, hemoglobin is always remains this, I take correction, it improves, then again it comes back to this, then we will require myelodysplastic syndrome. So that has to be ruled. I hope I answered the question.
Yes, sir. But LDH and B12 will be high, is it?
High. Yes, it will always be high. Okay, because you are having
And
intramedullary hemolysis in this. So LDH will always be high. Because what happens because vitamin B12 is required for a formation of RBC. And if vitamin B12 is not given, there's a asynchrony between a nucleus formation and the cytoplasm formation, leading to big megaloblast, which are very fragile in nature and they break off very easily.
yes, sir. Thank you so much. It was really helpful.
Any other questions? So should I go to the next patient?
So there are few questions in the chat box as well.
Okay, can I take them at the end? If you don't mind, I'll just finish off the patient.
Okay, sir. Okay, you can continue.
Yeah.
Yeah, please
Yeah.
continue.
Yeah. So patient number 2 came to emergency with sudden syncope, headache, and palpitation. History of weight loss approximately 10 kilograms since 1 month is there. Patient was afebrile, tachycardic, normal BP, pallor and icterus were present. CBC showed severe anemia, HB of 5, MCV of 72, platelets of 10,000. Indirect bilirubin was 5, creat was 1.4, slightly high, LDH was 1,885, and retic was 18.7. We did PT, APTT, fibrinogen that turned out to be normal. Peripheral smear showed cystocyte 6 to 7%. So what could be the diagnosis you are looking at here?
Hemolytic anemia.
Okay, which type of hemolytic anemia? Would you like to point out something more than hemolytic anemia? Because you have cystocytes, so this is a very strong hint. Because and it's an emergency patient, so we have to take an emergency action, which I discussed in management. So you are looking at anybody else wants to take a somebody yes, so somebody I heard saying TTP. So you're looking at a microangiopathic hemolytic anemia. So you have to do a plasmin score that consists of creat, that consists of hemolysis, that consists of MCV, platelets, and the calculation. If you finding it anywhere between high risk, immediately start plasma exchange for the patient, and the patient will do well. Okay. Coming to patient number 3, a 16-year-old male presents with fever, diffuse pain in abdomen, fatigue, dark urine since 3 days. On examination, icterus pallor present, splenomegaly present, history or intake of anti-malarial drugs. This is the blood picture, and peripheral smear shows bite and hence bodies. Any diagnosis?
G6PD deficiency.
Yes. Okay. So at least some part of the topic has gone through to the students. I'm very happy. Thank you. Now I would like to take the questions which were pending.
I wanted to ask one question.
Yeah, please go ahead.
Yeah, in the patient number 2, why can't we keep a possibility of Hus also in the second patient? What could be the differential features from the MAHA from in that case?
No, so MAHA has TTP. MAHA also has Hus in it, urine.
Yeah.
So both are there. But if you look at the patient number 2, as you can see, patient was afebrile. Okay. So usually Hus will present with fever, which is an additional thing towards Hus. Okay.
That is the only thing. Or what I wanted to add, what will be in terms of, renal parameters as a Hus, hemolytic.
So between TTP, there's a pentad of TTP, which we didn't add here because neurological features are present. If you have a patient whom you are thinking between Hus and TTP, if a neurological feature is present, it is more towards TTP.
Okay.
If fever is present and then everything else is the same, it is more towards Hus. So these are the basic two difference. However, both of them in MAHA will present with cystocytes and immediately will require plasma exchange till you get the Adams 13.
Adam TS30.
Yeah, right.
Thank you very much.
Yeah.
So what was the, weight loss history suggestive of any particular reason or an indication for the history of loss weight approximately 10 kg over a period of 1 month?
Yeah.
In
So
this case, TTP,
yes.
any significance of that?
Yes. So no, not in terms of TTP, it is significant. But if you know APML can also present with DIC and can have an exact picture like this, except for peripheral smear will show promyelocytes. So in that case, a history of weight loss will be given to you. You will be thinking low platelets, low hemoglobin. Definitely, we are could be looking at a leukemia. Okay, so that is your first thought process. But when the peripheral smear comes, of course, you use out cystocytes here. So that's a different issue.
Okay, sir.
Some other question?
Sir, I have a question.
Yeah, sure.
We see in OPD, we get lot of this West Bengal patients with mild anemias, 9, 10, sometimes 8 also, with microcytic pictures and ferritin normal, most probably thinking in line of thalassemia trait. So how do we go about it, sir?
So, ma'am, one important thing I want to tell you here, when you look at a patient and you look at the peripheral index in front of you, please try to look at the point where RDW is given, and also try to look at the point how much is the RBC for the patient. Generally, if you calculate the indices for thalassemia trait, it is the traits will have lesser Minster's index compared to a iron deficiency anemia. So what happens is it is MCV divided by RBC. So if you look at the RBC for a thalassemia patient will usually be in the upper normal range or will be slightly above the normal. But RBC for a iron deficiency will be lower. So that is one thing. Second thing is RDW. RDW more than 14.5 is a good suggestion to do. However, one thing you should be very, very careful that you should ask the history of blood transfusion. If the iron deficiency was below 6 and 1 unit transfusion has been given, it's not like a thalassemia trait cannot present with iron deficiency anemia, especially in females. It can happen because they have menorrhagia, polymenorrhea, iron levels can drop. But once the transfusion has been given, how much time should we take to do HB electrophoresis becomes very important. Why? Because once you transfuse blood, the blood tends to stay in your body for 100 days. So if you do HB electrophoresis within that time, it will not show any benefit for the patient. And they might come get a normal report.
Okay. A confirmed case of thalassemia trait as a GP, what are the things I should counsel them about?
Ma'am, family counsel, if the patient is married or not married, is the most important counseling. If the patient is married, you have to request them to send the spouse sample also for HB electrophoresis. That is also very important because the child can develop a major or transfusion dependent. That is one thing. So family counseling is very important. Second thing is lifelong medications of folic acid and try to keep hemoglobin between 9 and 10. That is also extremely helpful in case of trait patients. So that's all they will rely, and family counseling is very important in that case.
Sir, use of folic acid in thalassemia trait for lifelong, is it compulsory if they are maintaining hemoglobin 9 and 10?
Generally, if they are maintaining hemoglobin 9 and 10, that will usually be on folic acid. But if they are maintaining 10 and 9 without folic acid, that's also okay. But remember, folic acid is a nutrient that is required to maintain the stability of the RBC. If folate deficiency occurs and they are not given, then RBC of thalassemia is very fragile. It will break and the hemoglobin will drop. So trait patient, since he has come to you, I doubt that they will have a good hemoglobin. Usually they will come to you when the hemoglobin is around 8. And that is the time when you have to take a call. Because most of us will not react if the hemoglobin is 10 for life, that is okay because we don't have much. So just one routine test once a year. But if he has come to you and you have picked up thalassemia, please suggest for folic acid to be.
And dosage is the same, sir?
Yeah, dosage is the same. Every day, 5 ml. Yeah. Then somebody they cast. Okay. Anybody who's putting questions to the chat, can you ask them directly? It will be helpful for us because I'm just seeing the screen and one screen is stuck. So I'm just telling out of memory. So that will be helpful.
Yeah, I'll try to.
Somebody has asked this question, how iron chelation is done. I hope, is the doctor there? So somebody has asked in thalassemia. So the thing is, if a transfusion dependent thalassemia is present in front of you, when we take for bone marrow transplant, there's a criteria where the high risk is evaluated. And the high risk is evaluated based on ferritin level that time and hepatic fibrosis scan that needs to be done and the age of the patient. So these three criteria are present. I think is the Luca system in which the criteria is that gives us a clue how successful will be the transplant. In high risk, if poorly maintained chelation and if the ferritin level is very high, generally the transplant result will be poor. So we have to maintain ferritin. Ideal situation, maintain it below 1000. Best situation around 500. But if not, at least definitely below 1000 we have to maintain so that we can give a good result during transplant. So there are three RN chelations. One is injectable, two are oral. They all have their side effects, which I'll discuss the next topic.
Right. Sir, good evening. I am Dr. Kingsley speaking. So, how to manage DAT negative autoimmune hemolytic anemia?
Yes. So as you know that negative, then we have to look at the other causes, whether it is towards microangiopathic or we are looking at any defect, whether it is a membrane defect, then they are all supportive causes only, or an enzyme defect, whether G6PD avoid the medicine, or if it is sickle or thalassemia, then again folic acid will help. If it's major, then definitely transplant will help. So in that negative, usually steroids do not have much role. So that's what we are trying to get.
So, what is the primary treatment for this DAT negative? So,
Sir, treat the underlying cause. Yes. Treat the underlying
Okay.
cause. Yeah. So we have to find the underlying cause. Why hemolysis is happening, although immune is non-immune.
Okay. Thank you.
Sir, if that positive, steroid should be lifelong, sir, or
No. So what is, yeah, it's a very good question. So I'll explain in a brief how we treat. Suppose we have a condition that the patient is DAT positive and it is 3+ positive, not weak positive, because malignancies also can have weak positive.
that positive means either it can be direct Coombs or indirect Coombs.
No, DAT is only direct. That full form is direct antiglobulin test. That is direct.
Okay.
And in your regular practice, you will deal with that only. Indirect wounds comes to if multiple transfusions are given to the patient. So that's where indirect or hereditary, if you are seeing a lot of pediatric patients. And then you will come to know hemolytic disease of the newborn. So coming to your question, suppose you have a patient which is DAT positive and the DAT DCT3 is 3+. Now, first rule out whether the patient is having any lymphoma. Once that has been ruled out, you have to start with steroids. Now, for the steroid treatment, how it starts is you have to give a pulse steroid. Okay, so once you give pulse steroid, we prefer giving dexamethasone 40 mg for 4 days. So once we give that, then we taper to prednisolone 1 mg per kg. And then based on that, we see how to taper. If the hemoglobin is dropping very fast on tapering 10%, then we add steroid sparing agent immediately. And what are the steroid sparing agents? They are azathioprine, danazol, dapsone, cyclosporin, MMF. These are the other agents there. They can be added. So the concept is to taper off steroids, hold with other agents for up to 2 years. If the patient is continuing to do well, then slowly start tapering the other agents also. This is how it presents. Sometimes, I'm sure you all are aware of Evans syndrome, right? In which ITP will develop and with time autoimmune hemolytic anemia will also develop. So both can be present. So in those cases, since ITP requires fast tapering, while autoimmune requires slow tapering, we still prefer slow tapering of steroids. Ma'am, I hope I answered your question.
Yes, sir. Thank you, sir.
Dr. Nishit, I have a question. Can you tell us a little bit about the G6PD deficiency and which are the commonest drugs which are the offenders?
Ma'am, I did mention anyway. The commonest are anti-malarial drugs and the antipsychotic drugs. These are the most common one in routine practice that they can present with G6PD deficiency. They are the most common one. Other than that, some amount of NSAIDs are also there. Some antibiotics like penicillin and ceftriaxone, they are also there, ma'am. But most common are anti-malarial and antipsychotic drugs. They can present G6PD if the
Which
patient is already.
antipsychotics out of your clinical
Ma'am,
experience?
phenobarbital is considered the most common, phenytoin, phenobarbital. So those groups are considered, not the SSRI group. The other groups are considered.
Thank you so much.
Sir, generally, whenever there's a DAD positive, we will do that IgM or IgG. Suppose if
Sir,
only IgM is positive.
Yes.
Sir, are you able to hear me, sir?
Yes, sir. Yes, I can hear you.
So whenever
Yes.
there's an IgM alone is positive, do we need to start steroids?
No. In IgM positive, if you get an IgM positive, please rule out mycoplasma. Okay. So infectious mononucleosis, you rule out that first. Okay. And then treat that. Okay. Because IgM will not respond much to steroid.
Yes. Okay. Thank you.
Somebody has asked how to work up for a sickle cell anemia case. And in pregnancy, we should do that or in that. Same person. Okay, somebody has asked how to work up for a sickle cell anemia case. So actually, it's a detailed topic in itself. For a sickle cell, we have to document how many acute chest syndrome occurred, how many times of avascular necrosis has happened, how many times hospitalization has happened. So if more than 3 hospitalization per year for consecutive of 3 years, any loss of any avascular necrosis, any loss of vision, and all these criteria are put together, even one of them, if present, the ideal treatment is bone marrow transplant. So in sickle, simple thing is, as the patient comes, they will already be diagnosed in around 1 year of age. All the hemoglobinopathies are usually diagnosed. Best around 6 months, but till 1 year, it is definitely diagnosed. Can anybody tell me why takes about a year to diagnose?
Fetal hemoglobin replaced.
Yeah, so there'll be a switch over from the fetal hemoglobin to the HbA2. So where the diagnosis will come. So sickle cell, I'll definitely, if there's a topic regarding sickle cell separately, we'll discuss. In pregnancy, we usually do indirect Coombs test mostly.
For hereditary spherocytosis, what is the usual age of the presentation and how it will present?
So the first presentation, patient will come to a gastro. They will say a lot of gallstones are there and the patient is anemic and mild jaundice is there. That is the usual presentation. Nothing is required except for supportive treatment. So they will present somewhere after 3 to 8 years. That is the common side age group of presentation. They'll have repeated hospital admissions for anemia, gallstones, and this jaundice. Indirect will be high.
Sir, it's with blood
Sir,
transfusion.
good evening, sir.
Spherocytosis.
Yeah, good evening. Sorry,
Good
please.
evening. Good evening,
Sir,
sir. Sir, if the patient is a case of schizophrenia, who is on risperidone, shall we continue folic acid 5 mg?
Sir, what is the underlying thing you are suspecting? Like, I didn't get it. You think it is a
schizophrenia? Patient is on risperidone.
Okay. And you want to supplement why with folic acid? Is the patient anemic or something?
Patient is not anemic, sir, but as if so said, like a glucose 6-phosphate dehydrogenase deficiency will cause.
But we should establish that diagnosis because it's not very common to have G6PD.
Okay.
So we should have a established diagnosis for the same.
Okay, sir. Thank you, sir.
Somebody has asked Manjula B, pregnant woman with sickle cell trait with HB of 8, not improving with oral iron therapy for 1 month. How do you go about it? It depends on what pregnancy gestation is there. I would suggest to please give blood transfusions. The hemoglobin range for sickle cell has to be maintained between 9 and 10. not improving it, oral iron therapy for a month. For sickle cell, iron therapy will not be that useful because this falls into a different criteria of defect. Okay, ferritin will be generally normal and good. Any other questions? I think treatment of vitamin B12 deficiency, oral or IV. Definitely now there's a new data set. Amina, is she still there in the talk?
Yes, sir.
She has treatment in vitamin B12 deficiency. There's a good data to suggest methylcobalamin once daily for 3 months is equivalent to what the IV regimen we were giving. The doubt we used to usually have whether we should give IV or IM. For hemat practices, we usually prefer giving IV injections because IM can cause hematomas if the platelets was low. So that's a problem we might face. Some patches can develop. So, but now there's good data that oral methylcobalamin is also good replacement. So just that data has come with, I think, 2 months or 3 months back only. Dose of
Sir,
hydroxyurea, Manjuna
one
S
question
has
for
asked. Oh, sorry.
so one question regarding this vitamin B12 discussion ongoing. I want to ask any particular level of thrombocytopenia there we should avoid this vitamin IM vitamin D.
See, I generally avoid always IM in practice because doing regular blood test is also very tiresome for them. But as such, 50,000 and above is okay. So below that is what is considered critical.
Yes, sir. Okay, sir. Yes, sir. Thank
Somebody
you.
has asked the treatment of vitamin B12 deficiency. I've answered that. Somebody has asked dose of hydroxyurea for polycythemia. It is 500 mg OD. Any other questions? Please share your people.
Sir, in case of thalassemia trait, their hemoglobin will be somewhere around 9 or 10.
Yes.
And suppose if they are planning for any major surgery, is there any contraindication and whether we have to keep any blood transfusion in an emergency?
Okay. So it's always good to keep blood transfusions in emergency, but I know this is a common belief that hemoglobin level should be so much before we do a surgery. Is usually the platelet levels that determine the bleeding, not the HB level. So there's no contraindication as such. Okay, so all the guidelines for major surgery are based on the platelet level, but it's always good if patient bleeds profusely to have a good HB backup. But thalassemia trait will live a very normal life and they will not be disposed for any bleeding.
Any more questions?
I think I've answered all these questions here.
Yeah.
Thank you very much, sir.
Thank you, sir, for that comprehensive presentation. And see you all for the next call. And
there's a test coming up, so I hope you all do well. It's not that difficult. Just go through the PPT. I've already shared.
So one last question.
Yeah.
If in brief we'll get the G6PD deficiency evaluation, I mean, workup and management. I mean, what will be the last treatment for the G6PD deficiency?
Avoid
And,
the medicine is the last treatment because we don't get the Mediterranean type of G6PD in our country, luckily, because those are very severe G6PD. We have the minor type G6PD type B and variants, which are very mild in nature. So only mild hemolysis will be there. So avoid the causative agent. Patient will tend to do well. Okay.
Okay, sir.
Is there any other question which I have not answered and somebody has put in the chat? Please ask me. I've gone through the chat. I think I've answered all the questions. If anybody's question I've missed, I'm extremely sorry. You can ask me right now.
I don't think there are any questions, sir. Thank you very much for your comprehensive presentation and thank you all for joining in. Keep following the messages in the group for the test and feedback form. Thank you, everyone, and thank you very much, sir.
Thank you, everybody. Thank you for taking out your time.
Thank you.
Okay.
Thank you, sir.
Thank you, sir.
Please put the PPT in WhatsApp group, sir. Thank you.
It will be shared tomorrow. I request you all to leave the chat. And the meeting ends here. I request you all to log out. Thank you.
Thank you, ma'am.